السلام عليكم.
وعليكم السلام دكتور.
يا هلا، سامعاني؟
سامعينك.
تمام. والسكرين واضحة عندكم؟
واضحة.
تمام. أنا سمحت لكل الطلاب تشير سكرين كمان. مين كان معي بيحكي معي؟
أنا عبد الله عماد.
نعم.
عبد الله عماد.
عبد الله. عبد الله، أنت صوتك ما شاء الله عليك يعني كويس، فتقدر تقرأ لنا السيناريو من ننادي عليك، ممكن؟
أوكي حاضر.
أوكي، وتقرأ لنا الأسئلة لأنه صوتك واضح ومسموع.
أبلش؟
يعني أنا بستنى شوية الطلاب. ألو، سامعيني يعني؟
دكتور، بس الشاشة راحت، السكرين راح الشات كمان.
السكرين كأني كبست على إشي شغلة والسكرين أنه ستوبت. هسه هذه شايفيها للشاشة مو؟
لا لسه مش مبين إشي.
هلا
هسه رجعت.
تمام. عين. طيب، ممكن نبدأ. وعبد الله. So good afternoon. Today we'll have a small group discussion regarding case of peptic ulcer disease. This is one of the most important cases in the small group discussions and is very common. The scenario presented is very common scenario, and you are going in the future to see such cases, inshallah, after your. So Abdullah is going to read for us clinical scenario, and then we are going to make a summary for the important points in this scenario. As you know, and as we all know, that history taking give us a lot of clues and a lot of hints for the diagnosis of the condition. So Abdullah is going to read for us the clinical scenario, and then we are going to pick up the most important points in the scenario before answering the questions. Abdullah.
Case of peptic ulcer disease. A 46-year-old woman known to have chronic arthritis present to emergency room with vomiting of blood, hemoptysis. Prior to that,
hemoptysis. You pronounce it hemoptysis.
حاضر دكتور. hemoptysis.
Okay, excellent.
Prior to that, she was complaining of upper abdominal pain, aggravated by hunger, and revealed with antacid for several years. She takes painkillers for her joint pain only. Endoscopy was performed the same day she was admitted to the hospital and was found to have a 1 centimeter clean based ulcer in the duodenal bulb. without stigmata of active bleeding.
Okay. This is the case scenario. So we have 46-year-old woman, which is middle-aged woman, right? With a chronic arthritis. Once the scenario tells you that there is a chronic arthritis, it means that the patient is taking painkillers, analgesics, in order to relieve the pain of the joints. Yes? Presented with hematemesis. Hematemesis is, what is the meaning of hematemesis? Vomiting of blood. So as if the scenario telling us that there is something in the upper GI. The history of the patient that she has upper abdominal pain, hunger pain. Once the patient becomes hunger, يعني من يجوع المريض يصير عنده ألم. This is a sign of peptic ulcer disease. If she is going to eat and relieved by eating, this is a duodenal ulcer. Gastric ulcer, on the contrary, if the patient eats, the pain will be aggravated. يعني احنا كيف نفرق ما بين البeptic ulcer, whether it is a duodenal ulcer or gastric ulcer? When there is hunger pain, if the pain is relieved by eating, this is what? This is a duodenal ulcer. If the pain is increased, this is gastric ulcer. And the history confirmed what we have suspected, that she takes painkiller. Endoscopy when done, they found ulcer in the duodenal bulb. What is the duodenal bulb? Is the first part of the duodenum, which is about 5 centimeters. As we said in the introductory lecture, is the first part of the duodenum after the pyloric canal. Clear? And the endoscopy revealed no active bleeding from the ulcer, which is a good sign. So in summary, 46-year-old woman, chronic arthritis, taking painkiller, has hunger pain, relieved by eating, anti-acid also. Endoscopy revealed the duodenal ulcer, about 1 centimeter in the duodenal bulb. So we are dealing with a duodenal ulcer. Right. Abdullah, you can read for us the a question, starting with the question number 1, and we are going to answer it.
Discuss mechanism of HCl secretion of discuss mechanism of HCl secretion by the stomach.
Okay. Anybody could answer this question? I will make it more simple. From where the HCl is secreted, which type of cells? Anybody answer me?
Parietal cell.
Yes, excellent. Where we are seeing where the parietal cells are present?
In the stomach, the fundus, and the and the body.
Yes, in the body of the stomach, which is called corpus, right? Corpus, C-O-R-P-U-S. And near the antrum also. So parietal cells, which are oxyntic cells, are present in the body of the stomach, which is the corpus of the stomach, and also near the antrum. How this HCl is controlled? There are some materials that increase the excretion of HCl, and some others suppress the HCl excretion or secretion. What are the factors that increase the HCl secretion? Anybody could tell me?
Castran.
Gastrin, excellent. From where the gastrin is secreted?
The G cell.
G cell.
From G cells, excellent, yes. Where we find the G cells?
الأنترم.
Stomach.
In the antrum,
The
yes,
antrum.
good. And also, we may see them in the pyloric canal, mainly, in the pyloric canal mainly, and occasionally, sometimes in the duodenum. So the G cells are present in the antrum, pyloric canal, and occasionally in the duodenum. So gastrin will increase the HCl. What else can increase the HCl secretion?
Histamine.
Histamine, yes. From where we get the histamine?
Enterochromatin-like cells.
Yes, enterochromatin cells, which are present near the parietal cells, close to the parietal cells. We mentioned that the parietal cells are present in the corpus of the stomach and near the antrum. So the enterochromatin cells are close to the parietal cells. What else can increase the HCl secretion?
Acetylcholine.
Yes, excellent. Acetylcholine. From where we get the acetylcholine?
Neuron.
It's a neurotransmitter when the sympathetic and parasympathetic activated.
Yes, from the vagus nerve, parasympathetic, which is going to produce acetylcholine, and acetylcholine is going to increase the HCl secretion. So the main three factors: gastrin, histamine, acetylcholine. So in the treatment, we are going to mention that if you would like to suppress the HCl secretion, you have to suppress histamine, for example, and we will talk about it. What are the factors that can reduce the secretion of HCl? Anybody?
Serotonin.
Prostaglandin.
Yes. First of all, the first substance which is important in suppression of HCl. Tell me from where secretin is produced. Secretin, S starting with S, from S
cells.
cells,
The cell.
which are present in the duodenum. Right? So secretin produced from S cells, which are present in the duodenum, can suppress HCl secretion. What else can suppress HCl secretion?
Prostaglandin.
Yes. Right. Let us go into a bit more important substance, cholecystokinin. Cholecystokinin, which is secreted from the eye cells of the duodenum and the jejunum, correct? Cholecystokinin. And the last substance is somatostatin from the D cells or delta cells of the pancreas, antrum, and the duodenum. Mainly secreted from the pancreas, but also secreted from the antrum and the duodenum. All these can suppress, of course, the somatostatin can act on the parietal cells, also can suppress gastrin, also can suppress histamine. All of these effects at the end will suppress the HCl secretion. Clear to everybody? I'm sure you have been, these subjects have been covered to you in your lectures, but we are summarizing them just for the purpose of the lecture. The second question, Abdullah.
What is the hemoptysis and what is hemoptysis?
Yes. Now, you know, these two words in a pronunciation may look a bit similar. Hematomesis, hemoptysis. Hematomesis, we said, vomiting of a blood. Hemoptysis, coughing of a blood. The patient coughs blood. So what are the causes, the main causes of hematomesis, vomiting of blood? Let us start from the most common. Anybody could answer me? What are the main causes of hemoptysis? Hematomesis. What are the most common causes of vomiting blood?
Peptic ulcer.
Peptic ulcer, yes, okay. Peptic ulcer disease is a common cause of hematomesis. What else?
Tumor.
Tumor, yes. Tumor of what?
Stomach or esophagus.
Excellent. Tumor of stomach or esophagus can lead to hemoptysis. What else?
Varices.
Varices, yes. Where the
Infection?
varices?
Esophageal.
In the esophagus, yes. Esophageal varices. Very important cause of hematomesis. Esophageal varices, for example, that occurs with liver cirrhosis. Very important cause. Other cause? Another cause?
Gastritis ممكن.
Gastritis, yes. Common cause of hematomesis. There is erosion in the wall of the stomach, especially when a patient taking NSAIDs, for example, non-steroidal anti-inflammatory drugs, can cause erosion and also result in gastritis. Gastritis also can occur from other causes, for example, H. pylori, as we mentioned in our lecture. Another cause?
Mallory-Wilson syndrome.
Yes, Mallory-Weiss. Mallory-Weiss, in which, do you know what happened in Mallory-Weiss?
Esophageal ulcer.
In Mallory-Weiss, the patient, when has vomiting, severe vomiting, and repeated vomiting, right? It may lead to small breaks and erosions in the esophagus, and this may lead to hematomesis. So small breaks in the esophagus. And there are other conditions, schistosoma mansoni, and we are going to talk about it in the last lecture in GI module. And also there is a condition in which there is very severe ulcer in the duodenum, or probably you have tackled it in your pathology, called Zollinger-Ellison syndrome. These are the most important causes of hematomesis. What are the most important causes of hemoptysis, coughing of blood? The coughing of blood could be either frank blood, يعني كمية من الدم واضحة يعني blood, or sometimes streaks mixed with the sputum, streaks of blood mixed up with the sputum. So either a frank blood or streaks of blood with the sputum. Anybody could tell me the most important causes of hemoptysis?
Tuberculosis مثلا.
Pneumonia.
Tuberculosis, yes. What else? What about cancers?
Infection of
Cancer, what about
Pasabat.
cancers? Lung cancers, bronchogenic carcinoma. Yes, infection, pneumonia, bronchitis.
Blood clots.
Maybe, but in children, for example, foreign body may cause hemoptysis. And there are some conditions like sarcoidosis can lead to hemoptysis, trauma. Patient have a trauma on his chest may have hemoptysis. Mitral stenosis, by the way, mitral stenosis may lead to hemoptysis. Right. So could you read for us, Abdullah, any question about hemoptysis and hematemesis? We have covered it and the most important causes. Right?
أقرأ السؤال الأخير.
Yes. Question number 3.
Number 3. What are the causes of Baptic ulcer disease?
Yes, this is a good question. This is a good question. And we have to categorize it. What are the most important causes of peptic ulcer disease? Anybody could
infection.
answer me?
Non-steroidal
pyloric
anti-inflammatory disease.
Yes. 85% of the cases with peptic ulcer disease are due to H. pylori infection. And we have covered this point during our first lecture. Correct? So H. pylori infection. The second important causes for peptic ulcer disease, 15%, the remaining 15%, mostly are caused by NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen and others. So our patient is taking NSAIDs, painkiller. That is why she developed peptic ulcer disease. Still, there are other causes that may increase also the probability of occurrence of peptic ulcer disease. Steroids, for example. Steroid therapy may increase the development of peptic ulcer disease. إذا احنا بنحكي على non-steroidal anti-inflammatory drugs, of course, the steroid also can produce more effect on the stomach and produce peptic ulcer disease. Increased by tobacco, irritant, any irritant, for example, food, spicy food, etc. And there are certain diseases may contribute more to the development of H. pylori infection, like liver cirrhosis. Patients with liver cirrhosis are more prone to develop H. pylori infection. H. pylori, so when they have more H. pylori, so peptic ulcer disease will be more frequent. Anybody have any question?
Crohn's disease.
Crohn's disease, yes, good. Crohn's disease sometimes also can increase the probability of peptic ulcer disease. Excellent, good point. Although it is rare in comparison to what we have said. Question number 4, Abdullah.
How does patient with the peptic ulcer disease present?
Yes, we have answered this question along with the clinical manifestation or presentation of our patient. But let us repeat what the patient said, and also we can add to it some other points, which are important points, which are not present in our scenario. First of all, anybody could say for me what are the most common signs and symptoms of peptic ulcer disease?
Hematemesis.
Yes, we said hematemesis in our patient. What else?
Epigastric pain.
Yes, abdominal pain, let us say. Mainly at the epigastrium, epigastric pain. Excellent. More?
Maybe heartburn.
Yes, hunger pain. Our patient has hunger pain. And we said how to differentiate between gastric ulcer and duodenal ulcer. We said after eating, if disappeared, the pain disappeared, this is a duodenal ulcer. If increased, this is gastric ulcer. Interestingly, the hunger pain in a duodenal ulcer comes at night. So it is night abdominal pain. And it is improved with eating. Because the patient has got pain and related to food, hunger pain, they develop poor
Weight loss.
appetite. Poor appetite. يعني شهيته للأكل تصبح يعني compromised. تمام؟
ممكن
However,
ينزل وزنه.
I am saying this, 1/3 of the cases of peptic ulcer disease are asymptomatic, without symptoms, especially in old age. As I described in the lecture, I said difficult sometimes to diagnose in an old age peptic ulcer disease because sometimes it is attributed to indigestion. So هضم. تمام? Until the patient comes to you at one time with hemoptysis and perforation of the peptic ulcer, especially in old age. In old age, sometimes the first presentation of the patient is with hemoptysis and ulcer perforation. Any other?
Nausea and vomiting maybe.
Yeah, okay. Also can be. Let us go to question number 5. Abdullah.
What are the complications of peptic ulcer disease?
Yes. What are the complications? Some of them, we have mentioned them already in our discussion now. Anybody could repeat for me what we have mentioned regarding the complications of peptic ulcer disease?
Perforation of the blood vessel.
Yes, perforation and bleeding, yeah. Perforation of a duodenal ulcer, perforation of the gastric ulcer. And the perforation is very dangerous condition. The patient will get peritonitis and acute abdomen. The second one is bleeding, yes. Either a frank bleeding presented as hemoptysis, or sometimes the bleeding, this occurs in about 15% of the cases of peptic ulcer disease. The patient sometimes get microscopic bleeding, oozing of blood, small amounts continuously. That is why we have to do a test to see whether the patient has got this microscopic bleeding called occult blood, OCCULT, occult blood. Is a stool examination for the presence of destructed RBC called occult blood, OCCULT. You can read about it. Another complication, anybody could mention it to me?
Blockage of the stomach.
Yes, pyloric canal obstruction due to fibrosis. You know, if you have ulcer at the area, in the pyloric canal, for example, or in the duodenal bulb, and for a long time, this will result in what? Will result in fibrosis. We have 10 minutes. If we haven't finished, we will re-enter again to the same link. Okay, for everybody? All right. So due to fibrosis, we may get a blockage, and this is called pyloric obstruction. Sometimes it is complete obstruction. And the complete obstruction nowadays can be opened with ballooning, or by surgery, if not available surgery, and you can correct the obstruction and open the obstruction. Sometimes you get erosion of the stomach, as I said, and get a lot of manifestations from erosion. Right. Question number 6, Abdullah. Any question regarding the complications?
هل ممكن يعمل كارسينوما؟
Carcinoma?
أيوه.
Carcinoma is related to what I said in the lecture, that H. pylori infection for a long time could lead to metaplasia and then development of adenocarcinoma or maltoma, lymphoma. And this is related to the type of H. pylori and the genes they carry regarding GAG and VAG genes. Okay? Right. Question 6.
How to diagnose peptic ulcer disease?
Yeah. I spent a good time on the diagnosis of peptic ulcer disease during the lecture. And we have gone through a lot of details. But let us start that we have two important tests for the diagnosis of peptic ulcer disease.
Endoscopic.
What are these tests?
urea breathing test.
Yes, number one, and endoscopy, as your
والstool.
friend said
Okay.
just now. Endoscopy. So endoscopy as number one. Some people refuse to do endoscopy. Some people cannot tolerate to enter endoscope through their mouth and then to the esophagus. They cannot tolerate it for a reason or another. So urea breath test is an alternative, excellent method for the diagnosis. If we have done endoscopy, what we are going to find? We are going to find directly the ulcers and where they are, the type of the ulcer, whether there is a bleeding, stigmata of a bleeding, etc. The type of ulcers, age of the ulcer, depth of the ulcer, and so forth. And sometimes, as I mentioned, the location of the ulcer sometimes can tell us a lot. Ulcers on the lesser curvature may give us a clue, and ulcers on the greater curvature, for example, give us a clue, another clue. Right, so the location of the ulcer is important, and also in endoscopy, we can take biopsy. What we are going to do with the biopsy? Anybody?
Culture.
Culture, excellent. Culture will give us also a clue for the presence of H. pylori. We are looking for H. pylori by culture. What other thing from the biopsy? Rapid urea test. Yes, good. Rapid urea test. You put a piece of the biopsy in the urease media, and if it is convert the color from yellow to red within 5 hours, this is a good clue that we have H. pylori infection. And also histopathological staining to see the damage of the cells in the stomach or duodenum, and also the presence of the microorganism H. pylori. What other tests can be used for the diagnosis? Antibody detection against H. pylori using ELISA, right? Or other rapid tests. There are rapid tests for detection of these antibodies like IgG and IgA. Also, there is another test to detect the antigen in the stool.
Ammonia secretion in the stool.
Yes, if you have H. pylori present in the stomach, the antigen will be destroyed and will be passed through the stool, and you can detect the antigen in the stool. Although this is not useful in the Middle East. Why? Because we said up to 90-95% of people are carriers of H. pylori. Tamam? It is almost useless, but this test can be useful in exclusive methods. How? If a patient is negative for stool, H. pylori antigen. It means that he has no H. pylori infection. Most probably, not absolutely. Again, if the patient was positive and given a treatment and then the stool antigen disappeared, it means that the patient has been cured from the H. pylori infection. تمام؟ Any question?
كنت أسأل في بالإنترو أخذنا طريقة diagnosis اللي هي barium swallow. تنفع؟
تمام. Yes, by imaging. Yes, by imaging. Barium swallow. It's an old test قبل الاندوسكوبي وقبل اليوريا breath test, is a classical medicine. Barium swallow, and it is one of the important imaging procedure, classical procedure, which can be used for the detection of the peptic ulcer disease. But with the modern methods, endoscopy and biopsy and urea breath test, ELISA, the stool antigen, again by ELISA, nowadays we can use this modern technology. Question number 7.
What is the role of H. pylori in pathogenesis of peptic ulcer disease?
Yes. We have gone into a lot of details with this. We have 2 minutes, unfortunately. We have once finished, we have to re-enter again to complete our questions and answers. You remember I have mentioned many factors in the pathogenesis of H. pylori, the VAG-A, vacuolating cytotoxin A, and I said the VAG-A can cause damage to lysosomal and endosomal membrane, and GAG-A, cytotoxin associated gene A protein. So VAG-A, GAG-A, the GAG-A can cause effect on the cytoskeleton of the cell and damage it. And also OP-A, BAB-A. These are all factors contribute to the pathogenesis. And here we go to another point that many people in the Middle East, up to 95% of people, 85 to 95% of people in the Middle East are carriers of the H. pylori. And the question will be raised in Europe, usually less than 50%, 25 to 50% of people are carrier of the H. pylori. And the question will be raised, why some people are carriers of H. pylori and do not develop peptic ulcer disease, and why others are carriers of H. pylori and develop peptic ulcer disease. The question is related to the type of the virulent factors, the VAG-A, GAG-A, OP-A, BAB-A, especially VAG-A and GAG-A, and there are several. Hello? Assalamu alaikum.
وعليكم السلام.
Right. I was just saying that this pathogenic factor, VAG-A, GAG-A, OP-A, BAB-A, especially VAG-A, GAG-A, there are certain genes controlling them. So the susceptibility of the individual, it depends on the genetics of the H. pylori present, and also depends on the patient. Genetic factor, environmental factor, eating habits, smoking, drinking alcohol, and other things all contribute to the development of H. pylori infection and the development of peptic ulcer disease. Any question more? Question number 8, Abdullah.
How to diagnose H. pylori infection?
We mentioned that. We mentioned just in the previous question about peptic ulcer disease, because the main cause of peptic ulcer disease is H. pylori infection. So we are looking for H. pylori infection. And as I said, sometimes even in the clinics, outpatient clinic, we said endoscopy, we said urea breath test, but some people have got cartilage-like test just to detect antibody in the clinic regarding IgG or IgA. Although these are not diagnostic and not important, but when negative, they are exclusive. And also you can use them for a follow-up of the patient. If you give a treatment for the patient and the treatment is successful, you will find a drop in the concentration of this antibody, which we call a titer. And if not a drop, it means that the treatment was not successful enough. Any comment? Any question? All right, Abdullah, you can read the other question.
What is the role of non-steroidal anti-inflammatory drugs in pathogenesis of peptic ulcer disease?
Yes. We said that 85% of the cases are due to H. pylori infection, roughly speaking. And we said 15% are due to NSAIDs in the pathogenesis of peptic. But how the NSAIDs can do it? Anybody could explain it to us?
Yeah, I can.
COX-1 it's inhibit.
No. Yes.
It has local and systemic effect. Local, it's weak acid, so it may cause irritant for mucus. And the
Excellent.
systemic, it will inhibit COX-1, so it will decrease the prostaglandin. And this will lead to increase HCl and decrease mucosal production. So it will increase peptic ulcer.
Good. Excellent. So let us put it in a way that NSAIDs can suppress a prostaglandin. Yes, there are different prostaglandin. You know, prostaglandin are called PG, PGE2, D2, I2, F2 alpha, and also can suppress a thromboxane, like a thromboxane A2. When these are suppressed, right, the prostaglandin secretion, they suppress also the enzymes. There are 3 enzymes which are COX-1, COX-2, and COX-3. Now, once you get suppression of the enzymes, these COX enzyme, which are cyclooxygenase enzymes, you will get suppression of the prostaglandin. What is the function of a prostaglandin? GI cytoprotection, protection of the epithelial lining. If you suppress the enzymes, then suppress the prostaglandin, you get less protection to the gastrointestinal epithelial cells, especially in the stomach and the duodenum. هذه تمثل البروستاجلاندين حماية to the epithelial lining of the stomach and the duodenum. So they have started to think that let us make the NSAIDs a bit less damaging. They produce what is called COX-1 sparing NSAIDs. That is to say, they suppress the effect of COX-2. على الأقل تخفف من المشكلة. يعني COX-1 يبقى و COX-2 will be inhibited. Just to make the effect less on the damaging of the epithelium of the stomach. They produce some drugs like celecoxib, celecoxib, C-E-L-E-C-O-X-I-P. Celecoxib, this is COX-1 sparing NSAIDs. And although they found later on also can cause damage and may lead to the unwanted complication of bleeding and perforation. Anyhow, sometimes the reason for that is that there is severe suppression of a prostaglandin. So you have two options. Either you give, the damage and irritation can occur with HCl. Tamam? So either you suppress the acid, and suppression of the acid HCl secretion can be done with a proton pump inhibitor, like lansoprazole, right? So you do suppression of the acid, or previously, before forbidden, the H2 blockers like cimetidine and ranitidine, although nowadays are not in use, they have been removed from the market. So either you use a proton pump inhibitor just to protect the stomach from the acidity and the duodenum from the acidity, or you can have alternative way to give a prostaglandin analog in order just to protect the, we said the prostaglandin are GI cytoprotectin. They do cytoprotection. You can give, for example, a prostaglandin analog like misoprostol. Misoprostol. Miso, M-I-S-O, prostol, P-R-O-S-T-O-L. This is a prostaglandin analog. Especially you can give it to old people who are susceptible, and usually they are in need to NSAIDs because of the different rheumatic diseases, and to those people who are on long taking regimen of NSAIDs. I hope this is clear to you now. Any comment, any question? Okay, we go to question number 10.
How to treat H. pylori infection?
Okay. I have tackled this point in the lecture, and we said we have the triple therapy and we have the quadruple therapy. The triple therapy, anybody could mention it to me?
amoxicillin,
The
erythromycin,
triple therapy for H. pylori. We use a proton pump inhibitor plus 2 antibiotics, either a clarithromycin plus amoxicillin or metronidazole. Alternative to it, we said we use levofloxacin or tetracycline plus metronidazole. This is the triple therapy, and I have explained it to you in the lecture in details. The quadruple therapy, the same thing, plus bismuth subsalicylate, which is pepto-bismol. And I have shown you a picture for the pepto-bismol. You can repeat it and you can read it again just to master the details. The last question.
دكتور أنا مبين عندي بس السؤال العاشر.
تمام. The last one. Now open to you.
How to treat and prevent NSAID related?
Yes, we have mentioned this. We have gone into a lot of details regarding the NSAIDs ulceration, and we said a prostaglandin analog, PPI, H2 blocker, antiacid, right, and misoprostol. All these, the best way is to stop NSAIDs, if possible. But if not possible, you can use the alternatives that I have mentioned. Nowadays, in many countries, it is by law, you cannot give NSAIDs without a proton pump inhibitor. You cannot prescribe NSAIDs without taking a proton pump inhibitor or antiacid, and previously with H2 blocker, just from theoretical point of view, like ranitidine, cimetidine, that was stopped by now. And also you can give misoprostol for long taking regimen, and in old people, misoprostol, as I said, is a prostaglandin analog. Any question? I hope you have got the benefit from this small group discussion, and any question you have, you can ask me after the lectures, or you can send me emails. Any comment, any question?
الله يعطيك العافية دكتور.
الله يعافيكم عيني. إن شاء الله نشوفكم في المحاضرات. السلام عليكم.